evening, everybody. Thank you, Darren. My name is Michelle Batty. I'm the manager of the European reference network called eUROGEN, and I work for Radboud University Medical Centre in the Netherlands. eUROGEN is one of 24 European reference networks which were created by the European Commission in 2017. They're virtual networks of healthcare providers with highly specialised expertise in rare and complex conditions. And they all work together to improve diagnosis, treatment and management of patients with these rare diseases and complex conditions. And we know that no one country alone has got the expertise to deal with all 6,000 to 8,000 rare diseases, and no one country has sufficient patient numbers to conduct effective research. So there's huge value and potential at cooperating at European level, and that's what we've been doing since 2017. And I would just like to highlight that something that the reference networks are now offering to all clinicians across the EU is that we have a secure virtual IT platform where we can upload a patient's medical history and imaging, and you can contact the ERN expert clinicians for advice on a patient if they have a particular rare or complex condition and you'd like the opinion of others. So please don't be shy, contact us via our network, and we're very happy to try and help spread knowledge as much as we can. So this evening's webinar is about posterior urethral valves, the treatment and follow-up from a pediatric urological perspective. And I'm really delighted to welcome two very active members of the reference network from Sweden. So we have Gundela Holmdahl, who is Associate Professor and Senior Consultant, and she's team leader of the pediatric urology section at Karolinska University Hospital in Stockholm. And we also have Sofia Sjöström, who is Associate Professor and Senior Consultant and Team Leader of the Pediatric Urology Section at the Queen Silvia Children's Hospital in Gothenburg. So ladies, thank you so much for sharing your expertise with us, and we're really looking forward to your talk. Thank you, the floor is yours.
Thank you for a kind introduction. And now I'm asking if you can see our presentation.
Yeah, just need to put it into full presentation mode, I think. That's all.
Yes.
Great, that's good.
And I think you're at the end of the presentation.
Okay.
Okay.
So, thank you for a nice introduction. We would like to present this webinar on posterior urethral valves. Okay, we are at the last picture.
So, go there.
Starting. Now, okay, from the beginning. So, we will have about 30 minutes presentation, and it will be followed by 15 minutes for answering questions and comments from the audience. And we have nothing to declare. Right. So to start on, posterior urethral valves are obstructing membranous folds within the lumen of the posterior urethra. It occurs in boys only, and the incidence is about 1 to 5,000 pregnancies. The cause of the condition is still unknown, but it's due to disrupted development of male urethra happening sometime in gestational week 9 to 14. It's the most common etiology of urinary tract obstruction in newborn males, and it's the most common cause of chronic kidney disease due to urinary tract obstruction in children. Way of presentation in approximately 1/3 of cases is antenatal findings on ultrasound, such as megacystis, often combined with dilatation of proximal urethra, seen as keyhole sign, and uni or bilateral dilatation of the upper urinary tract. A more worrying sign is the finding of oligohydramnios, especially when detected early in pregnancy, as normal level of vesicoureteral fluid is warranted for continued lung development in gestational week 16 to 28. Increased pressure in the urinary tract proximal to the obstruction may lead to perforation with urinary tract leakage, seen as perinephric urinoma or fetal ascites. Other prenatal findings can be increased renal echogenicity and cortical cysts as a sign of renal dysplasia. Patients that are not identified antenatally are usually diagnosed early in infancy with respiratory distress due to lung hypoplasia, urosepsis, poor urinary stream, palpable enlarged bladder or hydronephrosis, or failure to thrive. Occasionally, posterior urethral valves are diagnosed later in older children with symptoms such as repeated urinary tract infections and bladder dysfunction with day and nighttime incontinence. The risk of perinatal mortality and morbidity is higher if findings of suspected PUV are noted early in pregnancy with severe bilateral hydronephrosis and oligohydramnios. The mortality rate in boys with PUV is about 5 to 10%. The primary reason for early death is respiratory distress due to lung hypoplasia. Since the early 80s, prenatal intervention of posterior urethral valves has been evaluated, but is still not considered first-line treatment. The vast majority of cases should be treated soon after birth, since there's a high risk of fetal and maternal mortality and morbidity in prenatal interventions for PUV. Fetal surgical intervention in obstructive uropathy aims to restore amniotic fluid levels, to prevent lung hypoplasia, and to relieve the obstruction with back pressure on the upper urinary tract to reduce risk of renal damage. Fetal surgery might still be the future, but until more robust results, it should be reserved for selected cases only, when there is a high risk of in utero or neonatal death due to early severe oligohydramnios. In those cases, it should be performed at high volume centers with special expertise. In most cases, treatment is initiated soon after birth, and the treatment aims at resuscitation and stabilization of vital functions. Correction of electrolytes and acidosis is crucial, as well as monitoring of urine production hour by hour. If signs of urosepsis, antibiotic treatment should be prompt and without delay. The bladder should be drained, preferably by a soft baby feeding tube without a cuff, since there's a risk of misplacement of the balloon in the posterior urethra, compromising the urinary drainage. The catheter can be guided into the right position in the bladder by simultaneous ultrasound. Early investigations include ultrasonography of the kidneys, ureters, and bladder. Voiding cystourethrogram, where the diagnosis often is nailed down. Cystoscopy is mandatory both for diagnosis and treatment of valves. Renal scans, either static or dynamic, and repeated serum creatinine measurements until stabilization, the nadir point, are necessary for evaluation of renal function. Early interventions are first of all bladder drainage, urethral or suprapubic. Valve ablation can be considered early to start to cycle the bladder. If poor drainage of bladder and or upper urinary tract, a vesicostomy can be a preferred method. In cases of low urinary production due to distal urethral obstruction caused by the thick-walled bladder, measures of high urinary diversion, such as percutaneous nephrostomies or ureterostomies, can be necessary. Early introduction of CIC after valve ablation is recommended in selected cases, and Gundela will comment on that later. Medical treatment is tailored in cooperation with the pediatric nephrologist and depending on renal function. Antibiotic prophylactic treatment during the first year of life to prevent urinary tract infection is a common strategy. Anticholinergic treatment to reduce bladder dysfunction caused by a thick-walled bladder with low compliance is also considered optional already during infancy. Oral substitution with sodium and bicarbonate can be necessary to support normal growth and reduce risk of metabolic acidosis due to lowered renal function. Some also need alpha-calcidol to substitute for vitamin D deficiency to prevent from mineral and bone disorders. Of all prognostic factors, nadir's serum creatinine at 12 months of age seems the most important one in predicting development of end-stage renal disease in PUV patients. This is a consistent finding in several studies with large cohorts of PUV patients. Associated anomalies of the urinary tract are common, as for example vesicoureteral reflux. It's seen in about 50% of PUV patients. Reflux is considered secondary to increased vesical pressure from outlet obstruction, leading to failure of the normal development of the valve mechanism between the bladder and distal ureter. Reflux, especially in bilateral cases, is a well-known risk factor for end-stage renal disease in involved patients. Chronic kidney disease in those patients is mainly the result of renal dysplasia, already seen in antenatal USG in about 60%. But repeated febrile UTIs and bladder dysfunction can also lead to deterioration. VURD syndrome is the name for unilateral high-grade reflux with ipsilateral dysplastic or non-functioning kidney. There are theories of a pop-off mechanism where unilateral high-grade reflux or a perforation with a perinephric urinoma lowers the intravesical pressure, resulting in protection of the development of the contralateral kidney. Overall aim with all treatment in children with urethral valves are to reduce morbidity and minimize complication or harms from unnecessary treatment and investigations. Multidisciplinary care is necessary, and we do work close together with the pediatric nephrologist and urotherapist to achieve the best individualized design treatment for each child. Now, let me present the case, and you will get the opportunity to suggest treatment with pulse. This boy was born in gestational week 40, birth weight 4,050 grams. He had antenatal bilateral hydronephrosis and megacystis, confirmed by postnatal USG. He had no respiratory problems, and a VCUG at day 3 showed a typical posterior urethral valve and left-sided high-grade reflux. He was treated with antibiotic prophylactics from day 3. He had a transurethral catheter that was dislocated and did not drain the bladder, so he got a suprapubic tube at day 4. He had initial good urine production, but at day 5, he shows sign of urosepsis, rising CRP and serum creatinine. He's acidotic and he has hyperkalemia. During a couple of hours, he's anuric despite fluid substitution. Besides antibiotic treatment and correction of electrolytes and acidosis, what will be your next step of action? Watchful waiting, bilateral percutaneous nephrostomies, open diversions, bilateral ureterostomies, or preparing for dialysis.
Okay, I'm going to launch the poll now.
Thank you.
And then you'll give people a few moments to fill that in. I'll just wait for the results to settle down and then we'll close it. Okay, so I think we're just about there. So I'll say 5, 4, 3, 2, 1. We'll close the poll. So I should show the results.
Okay. Is this me?
Can you see the results?
No.
Oh, you can't. Okay.
Can we check with that?
So I can give you the results. Sorry, watchful waiting 24%, bilateral percutaneous nephrostomies 45%, open diversions 30%, and preparing for dialysis 0%.
Thank you. Okay. Thank you very much. And next picture for us. Now we can't move our presentation. Okay, now, good.
Yeah.
Right or wrong, we had percutaneous bilateral nephrostomies, as the majority of our audience inserted. Urine production and drainage was secured, and the boy went polyuric for some days, but recovered well from his urosepsis. Urinary culture showed Enterobacter and ESBL producing E. coli. He was treated with intravenous antibiotics for 10 days. The pyelostomy of the left kidney had very low urine production and was extracted after 5 days. Right pyelostomy extracted at day 20 after antegrade pyelography that showed passage to bladder without major delay. A DMSA scan at about 1 month of age showed differential renal function left side of only 13%. He had an uptake defect, focal scar caudally in the right kidney. At 1 month of age, we performed cold cat valve ablation. The SB catheter was withdrawn and he got a transurethral catheter for 3 days postoperatively. So at 1 year follow-up, the boy was doing well. He gained height and weight and had no other medication than prophylactic antibiotics. He has had another 4 febrile UTIs during his first year of life, mainly with ESBL producing E. coli. He has been treated with intravenous antibiotics each time and he has had good recovery. Nadir creatinine is 34 micromole per liter, slightly elevated, and GFR is 52 milliliters per minute, corrected. MAG3 scan shows very low function of left kidney, now 8%, and delayed outflow of right kidney without parenchymal defects and with a dilated ureter. USG shows persistent bilateral hydronephrosis, but less severe, APD 10 to 13 millimeters. Avoiding observation shows small bladder capacity with complete emptying. What will be your further action at this point? Close surveillance, antibiotic prophylactics, anticholinergic medication and early potty training. Vesicostomy, left side refluxing ureterostomy, or left side nephrectomy.
Okay, I'm going to launch that poll now. Give everyone 20-30 seconds. Okay, 5, 4, 3, 2, 1, and we close it. So the results there, so one surveillance 42%, vesicostomy 21%, left-sided refluxing ureterostomy 13%, and left-side nephrectomy 24%.
Okay, thank you. Again, interesting result. We went for conservative treatment, as the majority of the audience, and he's now 7 years old and he's doing well. He had no more febrile UTIs after potty training. His reflux resolved spontaneously. He's dry night and day, except rare occasions of postponement. He has normal flow curves with a Qmax of 19 milliliters per second and a residual less than 10 milliliters. He has normal blood pressure and no proteinuria. He has stable or even improved renal function with the GFR measurement of 73 milliliters per minute corrected. And he's on continued follow-up in the uronephrological department. So Gundela, what about continued follow-up and treatment?
Okay, thank you, Sofia. I will take over.
Good.
And talk about the management after the initial treatment. It's quite strange to just talk to a screen, but I hope it will do all right. Well, we all agree that the aim of the treatment of boys with valves is to save renal function and rehabilitate the bladder. But how good have we historically succeeded to do this? 50% of the boys will as adults have a normal renal function, but 20 to 30% will develop end-stage renal disease during their lifetime. Finnish studies tells us that low urinary tract symptoms are twice as common in men with valves. I will not talk about reproduction in this presentation, but the Finnish group also looked at sexual function and paternity and found that it is probably normal, but depending on the renal status. Sofia said before that the main risk factor for renal insufficiency is the nadir level of creatinine after valve resection, telling us that the grade of renal dysplasia is of utmost importance. These bad kidneys will have a low potential to grow, and in addition to this, several other factors have been discussed to affect renal function. An increase in creatinine and proteinuria are signs of kidney function deterioration, but factors as persisting hydronephrosis, bilateral reflux, recurrent UTI, persisting bladder dysfunction, and polyuria are potentially treatable. Well, we can't solve everything with surgery, and surgery of the secondary pathology in boys with valves has its drawbacks. First, of course, in an obstructive situation, you have to think of residual valves. It is good to be conservative concerning reflux, as reflux resolves spontaneously in most cases. And if it doesn't resolve, think bladder and treat that first. Deflux and neoimplantation in a thick-walled bladder can create problems with further obstruction. Nephrectomy of a non-functioning refluxing system can be good, as this reflux seldom downgrades and it can save the boy from the risk of UTI. But you should be aware also of the so-called pop-off mechanism that theoretically gives a low pressure situation for the contralateral kidney, even though you have a high pressure bladder. Urinary diversion, as vesicoureteral and ureterostomies, can be indicated in an unstable situation with UTIs and decreasing renal function, where other treatment options not are available. But it is still not proven that it saves renal function in the long run. There is also discussion what will happen to the bladder when it puts on rest. And that will take us to the bladder. We know that not all boys with valves will develop bladder dysfunction, and it's not always correlated to the grade of kidney damage. Some argue that bladder dysfunction in boys with valves should be prophylactically treated, for example with CIC, just in kids with spina bifida. But there is no clear evidence that is an advantage for the boys with valves. For what is it we want to treat? Incontinence is an important factor for health-related quality of life. In valve boys, the incontinence is mostly due to overactivity that will disappear with age. But in the meantime, it could be treated. Even more important is to treat emptying problems and low compliance, as this carries a risk of UTI and renal deterioration. So how should we treat the bladder dysfunction? The bladder dysfunction in boys will change with time and with other factors as polyuria, for example, and it is important to design the treatment for every clinical situation. The bladder after resection of the valves is in most cases small and overactive with discoordination, in some cases also with low compliance found at cystometry. The typical pattern is in a voiding observation, small interrupted voidings of 5 to 10 mils with the same amount left in the bladder. With time, most of the bladders with dysfunction will change to underactivity with emptying problems, what they call in the literature myogenic failure. Some bladders will remain overactive and some patients will develop a stiff, low compliant bladder. And that is a part of what is called the valve bladder syndrome. This situation is characterized of persisting upper tract dilatation, low compliant and thick wall bladder, and emptying problems. In a study by Koff, he argued that this was not only due to the congenital damaged bladder, but caused by sustained postnatal bladder overdistension due to a combination of polyuria, impaired bladder sensation, and residual urine volume. So that polyuria. Polyuria is due to an obstructive injury in renal collecting tubules, leading to impaired concentrating ability, giving rise to high urinary output. Polyuria is mentioned in many papers to be a risk factor for developing kidney damage and progressive bladder dysfunction, but it is not very much explored. Deanin presented 50 boys with valves, where nearly 60% had low urine osmolality. Interestingly, he found that the filtration rate was correlated to the concentrating ability and urinary output. Koff presented his 12 boys with polyuria treated with overnight drainage with a good effect on the hydronephrosis. Nagizadeh treated a group of boys with valves and polyuria with desmopressin and found that the response was stronger in patients with bladder dysfunction, hinting some sort of correlation. Wright compared boys with valves with and without some sort of bladder treatment or intervention and found that urine osmolality was reduced in the intervention group. The authors concluded that polyuria is associated with the progression of lower urinary tract dysfunction. The same group hypothesized a feedback loop in the deterioration of boys with valves, starting with a renal concentrating defect leading to polyuria, which in turn gives rise to a stretch injury to the bladder and in turn back pressure on the upper tract and so on. If this loop is of importance for deterioration, or if the polyuria is just a sign of the deteriorating kidney, still must be proven. Anyhow, in the figure, the authors give example of how to treat and stop the vicious circle. But to know when and how to treat, you must be able to assess the bladder first. The base of the bladder assessment is the history and voiding diary, of course. And that should also include a 24-hour drinking and voiding chart. But you can also ask the boy if he drinks at night. A simple question to look for signs of polyuria. Second step is non-invasive tools to evaluate the boy's emptying ability. For the non-toilet trained boy, it could be done with a 4-hour voiding observation, and in the older boy, repeated free flow and residuals. Invasive tools, cystometries, are only for selected patients. Catheterizing is difficult and troublesome for boys with valves, and in many cases, a suprapubic line is necessary. The cystometry can be done with a standard technique or as a video cystometry if this setting is available, and it's preferable in a reflux situation. Natural fill was a long time thought to be the future golden standard, but still it is only few centers using it. In our hands, cystometry is indicated only if you have signs of renal or bladder deterioration with emptying problems to guide the bladder treatment. It is also recommended before transplantation when the non-invasive tools indicate bladder dysfunction. The first advice in bladder treatment is early potty training. It has been shown that the boys empty the bladder better when they are toilet trained. Bladder regimen with scheduled and double voiding is probably also important, but it is difficult for a boy less than 7-8 years of age and even in older ages. Pharmacotherapy could be tried, and the most common is, of course, anticholinergics to stop overactivity. It is used in neonates to lower bladder pressure, but most commonly it is used to treat urge incontinence in the older children. Remember to always check progressive amounts of residual urine when giving it to valve boys. Alpha adrenergic blockers to enhance bladder emptying has also been reported to be effective. Bladder neck incision is an old method to cure emptying problems. It got bad reputation as it possibly could worsen incontinence and create risk for retrograde ejaculation when incising the hypertrophic bladder neck. But probably it is harmless in that sense, and it has gained popularity again. A less invasive method is Botox injections in the bladder neck, aiming at the same goal. Botox injection could possibly also be tried in the detrusor, but it's not very much investigated in boys with valves. For the emptying problems, the golden method is CIC. It is not easy to be done through urethra, but a metrophenol is a good alternative, and I will tell you some words about it later on. In a recent study of McLeod, boys with valves carry a 25% risk of need of CIC. Night drainage, as we said before, can be indicated if polyuria and can possibly delay renal deterioration. At least it can improve sleep. Last but not least, bladder augmentation is seldom indicated due to the development in most cases to an underactive bladder. But in cases when you must do an early transplantation, it could be needed. This could also be done post-transplantation, being aware of that a bladder can rehabilitate with a normal urinary output after transplantation. So back to the CIC. Due to this disturbed urethral anatomy and normal sensitivity in boys with valves, it is difficult to start and perform. The easiest time to start is in the infant year, but with a small overactive bladder in this age group with small amounts of residual urine, it is seldom indicated. With CIC through urethra, there is a risk of creating strictures, epididymitis, and UTI. There is also a big risk of non-compliance to treatment, especially during adolescence. So, in many boys, it could be an advantage to create a catheterizable stoma, a metrophenol from Monti. And a vesicectomy button can be a good option if polyuria needing night drainage before transplant, or when training and cycling the bladder before closing a vesicectomy. In the end, there are many questions left about the kidney and bladder in posterior urethral valves that still must be answered. And the heavier ones are if early diversion is important for renal preservation, what happens to the bladder after undiversion, what is the importance of the bladder function on renal deterioration, and what is the importance of polyuria. So I have also created a case for you. It's a boy with an antenatal diagnosis that postnatally showed valves with bilateral reflux and hydronephrosis. He had an early renal insufficiency. He was put on CIC from 1 year of age. The renal function decreased, and at 4 years of age, after the investigation before transplant, we did this cystometry where they see that he's a very small bladder. At B, you see where the big reflux comes to his non-functioning kidney. And then the pressure rises and he has a quite small, stiff bladder. So we decided to use that ureter to augment the bladder. And at 5 years of age, he was transplanted. The situation was quite under control for about 5 to 10 years. Then he came back at 15 years of age with decreasing renal function, with polyuria, with non-compliance with CIC. And you can see his cystometry now, where he has a bladder capacity of 400 mils, but a detrusor pressure at the end of filling of 30 centimeters of water. He had a suprapubic line inserted and he was now waiting for a new transplant. So here are your questions, and please, Darren, help us with the poll.
Yep. Okay, yeah, I can launch the poll straight away.
Shall I read the questions?
Yeah, no, just go through the options if you want, yeah, quickly.
Yeah. The first one is a Bricker deviation of the new kidney. The second one, a Mitrofanov. And the third one, keeping the suprapubic line to the transplant and evaluate it after the transplantation to see if it needs further CIC.
Okay, yeah, cool. Okay, I'll launch the poll now. Okay, there you go, everyone. Let's give it a few more seconds. Okay, I think that's settled there. So who wants to quickly else wants to vote, but otherwise I'll close it now.
We still can't see the answers.
So I'll share results. Sorry, I can tell you the results. So the Bricker deviation 6%, Mitrofanov 56%, and the final option 38%. You okay, Gundela? Sorry to carry on.
Sorry?
You okay to carry on? Yeah, sorry.
Yeah, but I can't see the answers.
Did you hear me read them out to you? Sorry.
Oh, I didn't. Can you do it again?
Yeah, sorry. So Bricker deviation 6%, Mitrofanov 56%, and the third option 38%.
Okay. That just shows how difficult this is. This boy, we gave him Mitrofanov. He had a severe infection afterwards with abscesses in the pelvis, with the lung infections, empyemas, went into respirators and gone into uremia, and had peritoneal or hemodialysis till he got his new kidney. But the Mitrofanov was very good. In the end, this boy had a very bad social situation, and now he's losing this kidney too, and he have never done catheterization in his Mitrofanov. So sometimes
it's hard.
It's hard to know what to do. So, our take-home message. Boys with valve bladder dysfunction and or renal impairment should be followed and have a designed treatment if needed of the bladder and kidney function. Do all agree? Thank you.
Thank you. And now I think it's open for questions and comments from the audience.
Should we?
Thank you for being so active with the polls. And we didn't manage to show the screen, but Darren had the results, and it showed that there are many ways to treat valves.
And the secondary pathology of it.
Yeah, I think
the valves
so too.
are easy, but the rest is very difficult.
Yeah.
And there are many opinions.
There are. And now let's see if there are any questions or comments from the audience.
So I've sent you one a few questions. Hopefully you'll be able to see them. So you should see the questions in the scroll list on the right hand side.
Okay,
we are trying.
Okay.
Can we make this a little bit bigger?
You can make it bigger. Yeah, if you click that little button on the right hand side, you should be able to.
Do you see a role for circumcision in valve boys? What do you say, Sofia?
I think
we are Swedes.
Yeah. The Swedes and the Italians, I've heard, have a very conservative approach to circumcision. But I think there is evidence that especially in infants with recurrent urinary tract infection, they could gain from circumcision or some kind of foreskin treatment. And in the case I had, we actually did, we treated him with corticosteroids to make it a bit more wide. But we could also have gone for circumcision, but it was the choice of the parents, and we awaited a bit further, and then he was out of infections. It would have taken one more anesthesia event, but it could have maybe saved him from some of the recurrent infections he had during his first year of life. So we do agree there is a role for circumcision in those patients, yes. Yeah, especially early on. Okay.
And here is another question. What is your personal opinion about alpha blockers? And I can say that we have no tradition using it in valve boys. I've used it quite a lot in functional bladder dysfunction.
With various results.
With various results, yes.
Because I agree with you, Gundela. In valve boys, rarely used. Sometimes in functional bladder dysfunction, I have tried it, and a few patients are helped, and some are not. Some develop enuresis instead.
Let's see.
Okay.
It's not easy. I don't know how you make this bigger.
No.
So, yeah. If you click on the questions grey tab, there's a little button on the right-hand side, which is like a little arrow. If you click on that, it'll undock it.
So, Gundela, there's a question for case 2. Would you give Botox intravesically?
And I would say, again, we haven't used Botox in those severe valve bladders with low compliance, as it was in the second case when he came back at 15 years of age. I think that in that acute situation, we had to put that bladder to rest. But of course you could, and it's very little written about it. And I will welcome a good study about it.
Can we ask the one that asked the question if he or she have experience of Botox intravesically in PUV patients? Can we get another comment on that?
Yeah, let's see if the person might want to type it in, or if they want to speak, maybe.
It would be good to get it commented on. Because different centers have different experiences in treatment options, so it could be good to.
So, Rihanna, if you'd like to let me know if you want to type that response or you want to speak about that. I've sent you another couple of questions through in the meantime. So.
Okay.
Yeah, okay.
Want to follow up?
Reflux in ureterostomy.
Well, if there is VURD syndrome with a pop-off mechanism and a low functional kidney on one side, and it could be both for the benefit to do a refluxing ureterostomy, and it could also to reduce intravesical pressure and to spare the function of the functional kidney. But we seldom do, actually, Gundela.
Yeah, I agree. We haven't done anything in any child with valves. And I think it's difficult when you have such a bad bladder as in valves, where the reflux is so dependent on the bladder function. So to have a reflux in ureterostomy working, it must be free reflux.
Yeah.
On the side. Okay.
And these are most often obstructive as well because of the thick bladder wall. Is that what you're saying?
What at?
That they are partly obstructive.
Yeah, I think so.
Okay, so we just go back to, I'm going to try and unmute Leanne so she can re-answer, she can speak to you about this.
Good, thank you.
Here we go. So Leanne, you
Yeah, I think it's working now.
Yeah, good.
Can you hear me?
Yes, we can.
Okay, great. My name is Rianne Lammers. I'm a fellow pediatric urology in Groningen, the Netherlands. And we do have some experience with valve boys giving Botox. I think it works rather well. I can't say any numbers by heart, but we do see that the compliance is improving. But of course, it helps. It does not help if the boy is not willing to do any form of catheterization.
Yes.
But the experience we have is that it helps for compliance.
And how often do you have to repeat it?
Sometimes we do it several times within a period of 3 to 6 months, with the idea, I don't know if there's any evidence for it, but with the idea that you have some kind of cumulative effect. But again, I don't know if there's any evidence for it.
Yeah. I know. Sorry.
Sorry. Hi, Marianne. Nice to hear from you. At what ages have you started on the treatment?
With the Botox, we have experience from a rather low age. So I think the youngest was 7 or 8 or something like that.
Okay. And I suppose you always try anticholinergic first.
Yeah, indeed. Yeah. So first we do monotherapy. If that's not working, then we do combined therapy. So most of the times anticholinergics combined with mirabegron, if I'm saying it correctly in English. And if that's not working, then we go on to Botox.
Mm. And the problem is that you have to have a boy that is catheterizing. That's right?
Could you repeat the question, please?
That you have to have a boy that catheterizes.
Yeah, of course. Yeah, because otherwise you have a problem with the urine retention.
Absolutely.
Yeah.
Yes.
So I think in case number 2, there probably you tried it, but I think in these boys, especially in the adolescents ones, it's really important to give them psychological help. So why is it so difficult for you to do the catheterization? What's your how can we help with that?
And I totally agree with you. Sometimes we don't reach them all the way, and especially when they are changing from the pediatric to the adult institutions. And again, how important isn't a urotherapist in this if you're going to manage CIC in a boy with valves?
Okay. Thank you for sharing your experience.
Here comes another question. Do you have experience with painful bladder spasm in valve bladders? I must admit that we haven't. I can't remember.
No, in some
really
other patients,
spasm.
but not in valve boys. No.
Huh?
No.
That was it. That is something about the UTI. No, that was about circumcision.
Do we have another question?
I think they're all the latest ones now. So
Okay.
I think maybe we've covered everything, hopefully. So yeah, we've actually only got about 5 minutes left, so that's taking quite a bit of time. That's good. Just quickly, I will say, if anyone's got any questions they think of later on, then please, you'll have my email address. Please email me. I can pass them on to Sofia and Gundela to get a response. Also, please check out the EUROGEN website for more details of forthcoming webinars as well. We have 2 a month from February onwards, I think, for most, at least up to the middle of the year. And as you sign up for this one, we'll also let you know about future ones as well. We'll keep you on a mailing list as well. So yeah, I think not had any other questions come in. So say thank you very much to Sofia and Gundela for an excellent presentation and a webinar, and thank you everyone for attending, and thank you for your questions. Yeah, I think just keep your eyes peeled for future sessions, and obviously, oh yeah, I will just say the recording of this webinar will be available on the GoToWebinars platform and also on our YouTube channel going forward. I will send out links to all the kind of registrants for those. So if you want to watch any of it back again, if I missed any of it, you can do so. But yeah, thank you again, Sofia and Gundela, and we'll hopefully see you again. Thank you.
Thank you, and thank Darren and Michelle, and thank
for
you
being inviting.
Yes, and thank you to the audience.
Yes.
Yeah, for being interactive.
You're still there. We see you.
Yeah. And next time we will be able to show the pulse on the screen. We missed that.
Yeah, I'm not sure what. So yeah.
Better next time. Better. Yeah.
Great. Thank you very much all. Cheers. Take care.
Thank you. Bye.
Goodbye.